you or show you where to access that online. Okay, looking at the next slide, which goes into the first element, at the top you'll see PCMH 1A, again looking at Standard 1, Element A, and patient-centered access. And as obviously noted there, this is the must-pass element. So again, when we look at the scoring, we'll look at what is required from that meaning. But this is looking at that the practice has a written process and defined standards for providing access to appointments and regularly assesses its performance on the various factors. So all of the numbered items listed within an element are the corresponding factors, and this is where points are aligned. The first factor, providing routine and urgent same-day appointments. So this is looking that in the office's schedule, there is allotted time each day for same-day appointments. This is in addition to your walk-in appointments, and it does not meet the factor if you are just adding unscheduled visits that you add to the end of the day or squeeze in at lunchtime. This is something that is scheduled, that you have allocated in your schedule beforehand for these appointments. Second factor is providing routine and urgent care appointments outside of the regular business hours. So if you have office hours for a few hours Saturday morning, or 1 or 2 nights a week are open until 7 o'clock, that's what they're looking for. Anything outside of the typical 9 to 5 workday, so that you are creating access for those patients that may not be able to take the time during the regular business day to come to an appointment. If a practice isn't able to provide these outside hours, they can arrange for patients to schedule appointments with other facilities, and this would just have to be explained and noted within the written policy or procedure. The third factor, providing alternative types of clinical encounters. A lot of questions around this and what exactly alternative clinical encounters are. But this is anything that is not your typical face-to-face in-office appointment. This is something that must, again, be scheduled, and it could be anything from telehealth, e-visits, home visits, group or shared appointments. But again, it just must be scheduled, and it has to address a medical or clinical need. So a telephone appointment can meet this factor if it's scheduled and it is discussing a clinical need. It can't be that a patient called in unscheduled and had a question about an upcoming appointment. It has to be scheduled and discussing something clinical. The fourth factor is looking at availability of appointments. So this is just looking at how easily different types of appointments are available. So your physicals, your wellness exams, just looking at the availability of the different appointment types. Fifth factor, monitoring no-show rates. That one's pretty straightforward. There's easy reports of this in MedEnt. Again, everyone, I'm sure, already notes and documents when a patient does not show up for an appointment, but this is just monitoring that and looking at how often this does occur. And the sixth and final factor for this element is acting on identified opportunities to improve access. So they want you to look at least one opportunity identified and create at least one action to improve access for that. So if you are looking at your no-show rates and see that they're higher than the office would like, it's coming up with some type of action to decrease that, whether it be more patient reminders or some type of outreach to get patients to their appointments, offering them resources for community transportation. If it's looking at your hours that you have outside of the regular business hours and seeing that you're open until 7 on Monday night and no one really utilizes that time, assessing what night or morning would be better for your patient population and changing that to improve access. So again, it's just looking at one opportunity and one action towards improving that. You'll see in red at the bottom the critical factor. So that for this element is factor number 1. There are, I believe, 9 critical factors throughout all of the standards, but the most important ones are those that fall within a must-pass element, because for scoring, you must achieve that one factor to get to the 50%, which is needed for the must-pass. So these are clearly identified in all of the documents from NCQA, and any documents you'll receive from me, I'll also be noting them this way. So just looking at the scoring and documentation now. On the left, you'll see the scoring. Again, as I mentioned, must-pass element. So you have to reach 50% to pass this element. It's worth 4.5 points. So to get the 50%, which is the minimum needed, you would need to achieve factor 1, which is the same-day appointment availability, and at least one other factor. Obviously, the more factors that you show proficiency in and documentation for, the higher points and eventually the higher level of recognition. On the right side, listing of the documentation requirements. So the way that this is noted, F1 through 6, is just identifying factors 1 through 6. So for each one, a documented process is needed. When they ask for a definition of appointments, they're just looking for routine versus urgent, showing that there's a difference, and if they're addressed differently, how the office goes about that. And then each factor has either a report, example, screenshot that is needed. Again, clearly trying to outline for you the time frame that is needed, whether it be a 5-day report, a report with a recent 30 calendar day period. Anytime that you see them talking about a recent time frame, they're speaking about in the last 12 months. So looking back, if we were running this report today to submit, anytime in the past 12 months that we could look at a 30-day calendar period, looking at factor number 3 here, that would be adequate for that factor. Just for documentation tips in general, again, like I mentioned, the reporting period is always identified, whether it be 7 days, 30 days. And also what they want is what they state here. So if they're just looking for one example or one screenshot or a 5-day report, that's all we need to submit to them. They won't give anything more or look at anything really more than what they ask for. They want it to be as concise as possible for what they're asking for. In the third bullet under the documentation, the bold, underline, red, or. Always looking out for the words and or. They will, again, specifically outline if there is a distinction, if they're looking for one or the other, or a documented process and a report. So always clearly look for that, and I'll always note that and point that out, make it obvious as well with any information that I'm sending. So that's the scoring and documentation requirements for element A. We're going to move on to the second element after we look at a few examples, and then go through some questions at the end of all 3 elements. So the slide has 2 examples, and something to keep in mind with any of these examples, they are just really tips and things for you to take some information from, and this is not all inclusive of what you would have to submit. A lot of these I'll show you an example of a policy or an example of a report, but keeping in mind that many times both of those things are required. So these are just to give you some examples and some help and guidance as to what exactly they're looking for. So on the left, this is an example of a policy for the same-day scheduling. You'll see there in the middle box just clearly explaining that they have an advanced access policy. They could be seen the same day if needed whenever the office is open. In factors, in elements that we'll look at coming forward, they want to be seen that a patient gets to see their personal physician, their preferred physician. But in this specific factor, that's not relevant. You could see anyone as long as it's available in that same day. So it's not a specific physician that you have to see if you call and request to come in the same day. It's just that it's available by someone in the practice. On the right side is an example for alternative clinical encounters. This is from the AAFP website, which has a lot of information about a lot of different areas of PCMH. But they have different tools that give information about e-visits as an alternative encounter type. This one on the screen is an example and explanation of shared medical appointments. So again, this is something that would be scheduled and be recorded and looked at as far as how this was a clinical scheduled encounter. And there's also no threshold for this of how often or how many need to be done. You can see that it requires a documented process for 30-day report, but there is nothing saying that every day for those 30 days one of these encounters had to happen, just that is scheduled within those 30 days. This slide is some examples of tools that are provided to look at different appointments. A lot of times there will be templates and examples that are either logs or Excel sheets to track different things. Some of these could be useful when they're just looking at a 5-day period, easily can put in some of that information, but a lot of this will be able to be run by Medent, different reporting methods. But this is just to give you an example that there are different methods of doing it. I know some offices it might be easier to do things manually, take things out of Medent that you need, create a report in Excel or elsewhere. So there are different methods. And also wanted to show on this slide the different annotations and organization for documenting exactly what factor and element you're looking at. So in the orange boxes, the annotations PCMH 1A1, which is referring to Standard 1, Element A, Factor 1. So that's the language and annotation that you'll see moving forward, and just a good way to keep track of what exactly the document is that you're working on. Moving on to the second element within Standard 1, 24/7 access to clinical advice. This element is looking at the practice has a written process and defined standards for providing access to clinical advice and continuity of medical record information at all times, and regularly assesses its performance. So again, the underlined and, it's looking at that you have a process and that you assess the process that you have in place. Factor 1 being the continuity of medical record information for care and advice when the office is closed. So in the process, they're looking for an explanation that this information is accessible and how it is accessible. Those are the two main points that they're looking for. It must be accessible to either on-call staff, external facilities, other providers, just that this information is accessible when the office is closed. It can be the office's policy that the facility arranges a phone call with a clinician who does have access to the medical record. If that's your process, it just needs to be explained that way. But again, just so that when the office is closed, there is a method to be able to access this information. The second factor, which is noted there as the critical factor for this element, providing timely clinical advice by telephone. They are looking that there is a time frame of response, and this is again defined by the office. So whatever is the appropriate time frame that your providers, your office sees fit to respond for information through the telephone, that is what you would explain in your process. The time frame and protocol can be different when the office is open compared to when the office is closed, and can also be different between if you're responding by phone and by email or any type of online response. Third factor, providing timely clinical advice using a secure interactive electronic system. The practice again defines what should be communicated electronically and what time frame for response. So for example, if someone is sending a secure message after hours that is an emergency, clearly, obviously stating to your patients that any type of emergency requires a phone call. Routine or non-urgent inquiries could be responded to the next day. Whatever your time frame is, whatever your office policy is, they're just looking that you do have something in place. Again, because you're going to be assessing if you meet that standard that you have in place. So this will help with, patients that either call or send a message and are complaining of not response. This is making accountable the office to get back to the patient in this time frame. The fourth factor, documenting clinical advice in the patient records. This is whether by phone or secure messaging, that there is a process in place of getting that information into the records. If this is documented or recorded outside of the medical record when the office is closed, then it just needs to be reconciled and put into the medical records the next business day. It's not looking that you have to have it at that time when the office is closed, that the physician would need to put it in right away, but just that gets reconciled within the next business day so that it's available for other providers and for the patient to see. The asterisk there for factor 3, if the practice cannot communicate electronically with patients, NA is an available response for this factor. And several factors moving forward, you will see this option. A lot of times it comes into play with differences between care for adults versus pediatrics. But anytime NA is a suitable option for your practice, it can be chosen and just needs to have a brief explanation as to why. Something as simple for this one is just that the practice can't communicate electronically. So looking at the scoring and documentation for element B, this is not a must-pass element, so there is no minimum that needs to be met, but because there is a critical factor within it, you do need to keep that in mind to get any points. For the documentation for factors 1 through 4, a documented process is needed. So for factor 1, again, explaining how the staff and patients have or can get access to medical records when the office is closed. For factor 2, a defined time frame of responding and monitoring your response times. And looking at the reports needed for factors 2 and 3, this is a 7-day calendar time. So those reports, again, are available in Medent right now. We've had them put these in. They might need a little bit of tweaking as far as the monitoring and making sure that it's against the threshold, the standard that your office has set. but this is, again, just a 7-day period that they're looking for. And just to note, you don't always have to meet the time requirement that you define or outline in your process. If you have the process stating that you will respond to telephone inquiries within 1 hour and you don't respond for 4 hours, that's fine as long as it's documented. It's not looking that you always have to meet that, just that you have a standard you're trying to achieve and that the office tries to get back to you in that time frame. Some examples of documentation for this element. On the left-hand side, this is just an example policy, a little piece of it. And at the top, you'll see that this says factors 1, 2, and 4. So a lot of times one document, one policy will be able to address several factors all in one with the information that it provides. So this is looking at that they calls during office hours are responded within 1 hour, and that the calls from patients are to be responded to by the on-call provider with 1 hour when the office is closed. So just highlighting some of the areas that they're looking for, and again, noting that you can use one policy to address several factors. On the right-hand side is an example of one of these logs that shows the date and time of when a patient called, when they responded, and if it's within that time frame that they stated as when they would like to get back to them. Again, this is just one way of showing what they're looking for. Again, this log is not the only way that this can be documented and shown, but just so that you get a look at what are the little details and specifics within it that they're looking for. This is probably not in your handout that I provided either. I added a few more examples. Again, on the left, just showing how a few factors can be in one policy. And exactly, again, just looking at their different after hours and during normal office hours, what their time frames are. On the right for this is looking at the call response in a patient's medical record. So this is something that can easily be shown, a screenshot of when this was provided and when that information is put into the medical record and that it's documented in there. Looking at element C, which is the last element within Standard 1, this is looking at electronic access. And again, this is where I said there is a lot of alignment with Stage 2 meaningful use. The practice provides through a secure electronic system. More than 50% of patients have online access to their health information within 4 business days of information being available to the practice. The patients don't have to have downloaded this information. It just needs to be accessible to them. Some different examples of things that they would want this access to or would need to be available: different blood tests, pulmonary tests, cardiac imaging, different radiology test results. So having the patients be able to access this within 4 business days of when the office has the information available. Factor 2, more than 5% of patients view and are provided the capability to download their health information or transmit their health information to a third party. So again, the and being essential there. They are able to view and capable to download to get credit for this. And again, for greater than 5% of the patients. Factor 3, clinical summaries provided for more than 50% of office visits within 1 business day. Number 4, secure message sent by more than 5% of patients. Again, you can see the asterisk here with Stage 2 meaningful use. A lot of you are probably familiar with some of these things because of meaningful use. Factor 5, patients have two-way communication with the practice. So in element B that we just talked about previously, where NA was an option for you if you can't communicate electronically, if you put NA for that factor, you would also have to put NA for this factor. Factor 6, patients may request appointments, prescription refills, referrals, and test results. So for this, you would just need to show where this is available as an option, not an example of where it was utilized. So this could be an office's website, through patient portal, through secure email, taking a screenshot of where in the portal they're able to request an appointment. That's all that they're looking for that factor. And again, noting that most of these do align with stage 2 meaningful use requirements. The scoring for element C, 2 points possible for this element. No critical factors within it, so the scoring is pretty straightforward. Another thing to keep in mind, looking at, for example, to achieve 100% to get the full 2 points for this element, you don't need to do all 6 factors. 5 of them still gets you to that 100%. So NCQA, knowing that not every office is going to be able to do all of these things, they give you leeway with some of these factors and don't need you to receive 100% for every single thing. Looking at the documentation of factors 1 through 4, they're looking for reports with at least 3 months of recent data. Again, recent data being within the past 12 months. Factors 5 and 6, screenshots showing the capability of the practice's website or portal. So for factor 5, again, showing the capability for two-way communication, and for factor 6, showing the capability to request appointments, medication refills, referrals, and get test results. So you'll see this is an area where they're just looking at the reports and the capability of your electronic system. There's no written process or documented policy for this. And some examples. On the left, you'll see a meaningful use report. You'll note that they wrote on there the date range. For reports, they're always looking for that date range. Again, this one is 3 months, so that's why they needed to clearly state that on there. And just little notes, annotations explaining exactly what this report is showing, just to make it easier for NCQA and, again, for our use to help that we're giving them what is needed. On the right side, factor 3 example, again, meaningful use requirements. This is looking at the meaningful use summary, obviously, which would be by provider, and they're the aggregated data for the office. So you'll see the summary and the averages from all the providers to give that information by office. So to this point, just going through those 3 elements and all of standard 1, does anyone have any questions, anything that I went over, anything that either wasn't clear or you would like some more information on? And also going forward, if there's any areas that you think would be beneficial to see an example or that I haven't provided, please let me know, and chances are I already have some examples or templates or guides for that that I could easily send over to you or discuss with you. Any questions?
No, come on, no questions.
Okay, then moving on to the next slide. Maybe. Okay. This slide, I just wanted to touch upon a few things, keeping in mind that the elements and factors that we're discussing aren't independent of each other. that they all fit together for a purpose. They don't just stand alone. Standard 1 is not just a checklist. Standard 2 is not a checklist. They all work together to help the office provide better care and give the patient better care and quality of care. So just looking at this diagram, training the team members, the team-based care is a big part of PCMH. It's emphasized throughout the standards. But by doing this and putting everyone in the office involved on the same page, knowing what they're responsible for, linking that with the managed care, with patient outreach, looking at different clinical outcomes, different quality improvement things that the office wants to achieve. All of these things are intertwined and come together to create, again, a better patient environment and better patient care and better satisfaction and efficiency for the office. Another thing to keep in mind is that PCMH recognition takes time and adjustments. Obviously, this is a lot of information. It could be a lot of changes for a lot of offices, but it's not something that is expected to come very quickly. And again, adjustments are going to be made along the way. We're going to find easier ways of doing things, better ways to document and to report. So working together and working with myself and with NCQA, we will be able to get these things in place for each office. The 2014 standards are new to everyone. These were just set and kind of the live standards as of April 1st of this year. So up until March 31st, everyone was able to still be working on 2011 standards. So in the past few weeks of working with MedEnt, they're still trying to find some conversions for 2014. They're still tweaking a lot of reports, care plans, different templates to help offices fit the needs for 2014. And again, I had mentioned earlier, any examples that are given as tools, guides, ideas, and they're not all inclusive of what is required. If you have any questions about any of the examples or exactly why something is adequate, or if something that you have, if you think that that would be sufficient, obviously we will discuss that together. But these are, I do have a lot of examples and tools, but I just don't want anyone to get caught up on any of that information and think what I'm showing is what they have to have. They're just there to help. The next slide is to kind of lay out a plan as to how these different elements are achievable and how most of the offices are already doing many of these things. What I've focused on so far and talked to a lot of you about are the must-pass elements. Again, those are on that second slide that I showed, those asterisk elements within each standard that you need at least 50% on to achieve any level recognition. So those 6 must-pass elements are obviously something that you want to focus on. Doing 100% of those gets you to 27.5 points, which is almost at level 1 already just by doing those 6 elements. Obviously, we want to achieve as much as possible, but again, getting the 50% of those that are needed to go forward with recognition. On the right-hand side are a list of things that some offices are either already doing completely or in some capacity. Meaningful use, PQRS, obviously the EHR capabilities. So this is just showing some of the elements where those things are directly aligned and the points that you can get just by showing your meaningful use report, looking at measures that you're reporting for PQRS, and choosing those different measures as what you would look at for PCMH. So hopefully that maybe eases your mind a little bit about achieving some of these things, achieving some of these points. So just looking at these two things can get you between a level 1 and almost to a level 2 recognition, just by some things that have to be done by everyone and some things that you're probably already doing in some regard. How to achieve some of these other factors. On the left, some things that are a little bit easier to do that you maybe might not be doing right now or are doing, but not to the extent or documentation requirements that they ask for. So the 24/7 access to clinical advice, which we just spoke about, creating a policy for that. And obviously there's a way that your practice responds to patients. There's a way that the providers get back to the patients when the office is closed or have access to them through email after hours. This is just putting it into a written form, which you may not have right now, but is something that can be achieved. Looking at medical home responsibilities, this is something that obviously I don't believe any office has in place, but this is just explaining to your patients and making it known exactly what a medical home is, providing brochures, materials, explaining what a medical home is. And this is something that I have a lot of brochures that can be given to patients, different example brochures, templates, and it's something that we'll talk about on the next meeting. As you can see, that's in Standard 2. So that just outlines some things that would probably be easily accessible, easily able to be implemented into the practice. And on the right-hand side, looking at things you might want to do in your office, things you've thought about in the past or things moving forward that make sense to be doing. Looking at the second bullet there, no-show appointments. So again, you obviously note that in some way that a patient didn't show up for an appointment, but you know what to do about that. So this would give you the ability that you're now having to monitor and assess this, and looking at how to decrease this rate. And again, whether it's through patient reminders or different ways that you get patients to come in. So this is addressing that. Training new staff, Standard 2, again, something that we'll talk about in the next meeting. But having these policies and process in place will help with some of those things. Training new staff, again, looking at who's responsible for what, and also having this in place when there's ever any staff turnover to hopefully ease that process and make it a little bit more streamlined. I mentioned PQRS, and that comes into play later in looking at obviously your clinical outcomes and your improvement measures. A lot of talk recently about transition of care and chronic care management. Chronic care management is a big part of PCMH, so working with a care team, working with that group of patients that you think would be that would have a benefit for care management. So those things are all ways to look at things that the office may want to be doing moving forward, or have thought about before, and how it ties into these things. All of these different programs and initiatives, meaningful use, PQRS, PCMH, they all tie together. They're all looking at creating better quality patient care and also better results and outcomes for the offices. The last slide is just some information and some things to keep in mind. As I mentioned, I'm looking to have these meetings every 2 to 3 weeks. Right now I'm looking at 2 weeks, so the next 2 being scheduled May 21st, which is a Thursday, and May 22nd, which is that Friday. And again, going in this format of looking at each standard and everything that is entailed within that standard. But if things would come up, recurrent questions, different areas to focus on, if it would be helpful to have one just on all of the must-pass elements, that's how we'll be moving forward with these meetings. I mentioned keeping documents named the same, annotated the same. That's obviously just going to be helpful for organization. We're going to have a lot of information and documents to upload and submit to NCQA. So just as a helpful reminder to everyone, coming up with some type of easy naming convention. A new policy template. I had distributed a lot of templates for different policies. I'm looking through one now that might help a little bit more standardization and streamline. As I get some more information and that a little bit more complete, I will let everyone know and distribute it appropriately. Again, if there's a factor or some type of piece within this that you haven't seen an example or a template for that you think would be helpful, let me know. I'm sure I have one, and if I don't, I can easily get one for you. If there's no other questions right now, I just wanted to bring up a few documents to show you quickly, just again for some more information and for your reference to some of these things. This is the document that I had mentioned that shows the alignment with meaningful use. You can see here, this is looking at standard 1, and where it fits, it will then describe to you the meaningful use alignment. They're all written the same. They all have the same thresholds for now. Again, as I mentioned, meaningful use might be making some adjustments in the coming months. If that's the case, this I'm sure will be tailored to those. But I just want to show you that this is the document that is available. I'm happy to send it to you, or I can direct you to where you could find it online. I also wanted to show you the tool that is actually submitted to NCQA. I'm going to be uploading and submitting all of this information, but I think it was easy for me once I actually purchased the tool and had it in front of me to understand, where's all this information going? How is it sent to NCQA? So this is the survey tool. This is the interactive tool that is used to upload your information and to send it to NCQA, and where NCQA reviews and scores. So as you see here, all the standards and the elements, and by going into this, I'm able to see, maybe. Okay, so standard 1, which we just went through, again, and this is laid out the same way it is if you've looked in the complete guide of the standard. The standard name at the top, the element here highlighted in red, all the factors that we just went through, the same annotation for critical factors, scoring information. This document tab is where I'll be able to upload all of the documents. The document name, and then I would be able to upload this, and once there are a few documents uploaded in here, one of the options that they give you is to link to elements. So this is where I said many policies, procedures, even reports can satisfy more than one factor with the information that is in there. So say, for instance, you upload your policy for appointment access, and that satisfies 3 factors that we talked about, when your office hours are outside the regular business day, and how the time frame is that your providers, that your office responds to patients. If that's all in one policy, we're able to clearly link that so that it's just one document having to be uploaded for several factors. So I just want to show you this, that this is what is actually going to be sent to NCQA. This is also where it's scored. We can look at, before we submit, anything that is put in here, NCQA never looks at until it's actually submitted. So if we had some things in here, we would be able to look at our overall score so far. Obviously, this is just by what we input. So this is just looking at that we had information uploaded and linked to all of these factors. This will show us if there's a specific factor or area that we didn't upload any information for, or we didn't check a yes or no box, just so that we don't miss anything before we submit. So that's a nice tool as well, so we know we don't miss anything and that we have something linked and uploaded for every area. Are there any questions on anything that we talked about all morning?
Yes, I have a question.
Sure.
When you were going over the call response, did I understand that is that part of the medical record in MEDN already?
Let me see exactly what.
Is there, like when you gave the example, is that a form that's in MEDN?
For a call response?
Yeah, it was under, it was after the 1B scoring and documentation. I don't have a copy of the screenshot that was on that you showed on your slideshow, but.
Sure. I believe what you're referring to was the examples response times to calls, where it showed the date that they responded, the time they responded, the elapsed time. Is that what you're referring to?
No. It was like it was a slide that you had shown right in that area though. That like the doctor would document, or the staff would document. It looked like, was it? I couldn't tell if it was actually in MEDN that the slide that you showed.
Okay, all of the examples that I showed, none of them came directly from MEDN. So I don't believe that what was shown is from MEDN. Won't let me look at my presentation again. But I'll look through it and send you an email and include it in the questions that I send out this afternoon of all the questions. But none of the examples that I showed were screenshots from MEDN.
Okay, because if we could have something in MEDN for the doctors to pull up as they're, most of them I'm sure are in triages. I don't know about other offices, but with our office, if the doctor responds, if a patient calls in, we send the doctor a triage, and it's documented there. If there was another form within MEDN that they could actually document all that on, that would be able to be submitted, I don't know.
Okay, yep, I completely understand what you're saying, and definitely with the triages, it's something that I'm looking at as far as working with NCQA to, if screenshots of those triages that are created for those different things is adequate, or going forward if we're going to need to put a different function in there. So I'll definitely get back to you with that.
Okay, thank you.
You're welcome. Any other questions? Well, if anything comes up, feel free to email me or call me any feedback or suggestions moving forward. And I will be sending out information about the next meeting again, which will be in 2 weeks, looking at Standard 2. And thank you everyone again for taking the time to listen and go through this morning, and have a good weekend.